All right, lung shunt. Let's touch on lung shunt. How are you calculating lung shunt post mapping?
Post mapping. So we do Planar.
You do Planar, okay?
We do Planar, and we also do SPECT CT, right? So we get Planar acquisitions, and we also do a SPECT CT. We were talking about MIM being wonderful. MIM can the AI associated with MIM can do your lung counts and your liver counts via SPECT. So actually our nuke med team, our nuke med techs will draw ROIs for lungs and liver, and as well as a background estimate, and then they'll calculate our counts on Planar imaging. By and large, that is good enough, right? What you'll learn is if you start drawing these on your own, slight little tweaks in volume can change lung shunts a fair amount. And the difference in lung dose going from 3% to 6% or vice versa is dramatic. That's half of the lung dose that you receive. And so I think that sometimes in a rad seg where my activity that I'm going to deliver to the tumor or to that perfused territory is very low.
Yeah, totally.
I don't necessarily
prescribed activity.
Yeah,
right?
Prescribed activity. When the prescribed activity is very low, I'm not really worried about what the total lung dose is or the lifetime lung dose is going to be, because it's going to be close to 3 gray at best. So I'm not going to go fight to redraw it. But if I'm doing a larger volume delivery with a much higher prescribed activity, that lung dose is going to be that it will matter, and it'll matter down the road. So you have to pay attention to how you calculate that. So for us, Planar, Nima, what do you do?
So we do both Planar and SPECT in terms of the type of images we acquire after the mapping, after the MAA. We use Planar as a default for our lung dose. When the Planar is elevated, the lung shunt is above 10%, we actually recalculate it using SPECT, because one of our own publications and a couple of others that have shown that when the lung shunt fraction is higher, the discrepancy between SPECT lung shunt fraction is higher on the Planar, there is a significantly more discrepant value calculated for the lung shunt fraction on SPECT CT versus Planar, and that can make a difference in terms of whether a patient is an eligible candidate for treatment or not, because of all the inaccuracies of doing the ROIs on the Planar.
I'll take it one step further. For me in my practice, everybody gets a SPECT CT lung shunt. That's how I dose. That's just what I do. Even if the Planar is 7%, I still do it. Now, I will say if I get like 1% on the SPECT CT lung shunt, I don't know that I'm going to use 1% necessarily. I'll give it a couple extra percent just to
be on the safe side. Yeah.
And a lot of the old radiation-induced lung injury data is based on Planar, correct?
Yes.
As well. Right?
In fact, everything that has been published to date is based on Planar, which is a big problem, because so the issue with Planar is not just not just a fraction, the volume of the lung. We just assume a 1 kilogram mass of the lung, whereas if you do the SPECT CT, you actually calculate the actual volume of the lung. And as both of you know, there's a significant discrepancy between the lung volume and, in effect, the mass between a female and a male. And the height of the patient, a lot of different factors goes into it,
But I think in the terms of, maybe not everybody has SPECT CT readily available or has. So MIM probably does your SPECT CT, or do you draw your lung?
So there's an auto contouring feature. I usually have to clean it up a little bit. So you spend a few minutes doing that.
But not everybody is going to have that kind of time and capability. So I think...
Or have access to the software platform.
And so I think Planar sometimes is the best you can do. There's different ways to do Planar, right? I think it's called geographic mean, where you do anterior and posterior, and it's an equation. We normally just draw it off the anterior. But I think it matters in this. You have to understand when it matters and when it doesn't matter, or when it's significant and when it's not significant. And you bring up great points about the differences in males and females and the difference in how much activity you're going to use. But not everybody has access to software to do these kind of things. When you're going to look at counts to the degree that, and we'll probably need to talk about this when we talk about partition dosimetry, whenever we decide to talk about it.
That's coming next, I promise.
Whenever we decide to talk about it. But software is critical for those kind of calculations.
I think to make it easy, kind of like, again, thinking about resources in different settings, I think if it is a low lung shunt fraction in a segmental, Planar is good enough. It's only when you want to do low bar and it's a high lung shunt fraction, that 1 to 2% difference between Planar and SPECT can make a significant difference. That is when you should ask if you don't have the software, even ask your nuclear medicine colleagues to actually recalculate the lung shunt on a SPECT.
The other thing I'll point out is if you don't have a breath hold acquisition, right? And it was one of my former co-residents, Doug Murray, who's in the Northwest, that turned me onto this. If you don't have a breath hold SPECT CT, I will actually contour my liver. I'll cheat a little bit into the lung to grab some of that activity that was actually in the liver, and then just misregister it in the bottom of the lung, and then bring that back into the liver to not affect my calculation. I do that commonly. I don't know if you both do that. The other thing I value with MIM, though, is I get that SPECT CT lung shunt, and I get that whole liver volume. So for me, the Mayo papers, I think, were very important in terms of percent liver treated when you're using ablative dosing. And so I really pay attention to whole liver volume and then my perfused volumes as well. But okay, great conversation.